Good morning. I'm Bonnie Gardner, co-chair of the Public Affairs Forum of the First Unitarian Universalist Church of Austin. Our forums are free and open to the public and occur almost every Sunday at noon. We're located at 4700 Grover Avenue. We strongly encourage you to attend. Today I am honored to introduce Lisa McGiffert. Lisa will be speaking on keeping patients safe, making progress, but still a long road ahead. She's going to talk about the advocacy work of Consumers Union, the Safe Patient Project, over the past decade, and will address issues of healthcare-acquired infections, medical errors, physician accountability. And she's going to highlight a recent initiative on the safety of medical implants that is pushing the medical industry to provide 20-year warranties on artificial knees and hips. These are very important public health issues. Lisa has been a very dedicated senior policy analyst for Consumers Union. She's also been a legislative coordinator for the Texas Senate Committee on Health and Human Services. She's worked on a broad range of healthcare policy issues in Texas and nationally, including health care quality, health insurance, access to care. She is directing the Safe Patient Project, which has initiated infection reporting legislation in almost every state. And she's drafted legislation and raised public awareness on preventing medical harm at the national level. She is a very important voice nationally on consumer safety and public health issues. So we're very fortunate to have Lisa. Let's give her a big hand.
Thank you. It's very good to be here. As Bonnie said, I am currently directing the Safe Patient Project of Consumers Union, and many of you probably know this, but Consumers Union is the advocacy arm of Consumer Reports, and that work is mainly based in New York, but we have a small office here in Texas that has been working here for quite some time. So we started this Safe Patient Project about 10 years ago in 2003, and we have a little tagline, End Secrecy, Save Lives. A lot of our work is about giving the public information about safety and how they can keep themselves safe in the healthcare system as a mechanism to bring about change in the healthcare system. We also want to bring the consumer voice into this arena because in the past, it's been pretty much healthcare providers, doctors, hospitals, all kinds of facilities and other kinds of providers are the prominent voices along with maybe academic researchers, those kinds of folks, but not so many consumer voices. We have a number of issues that we focus on, healthcare-acquired infections, medical errors, physician oversight, and medical device safety. So I'm going to jump right in and sort of talk to you about the problem. And I don't know how much you know about the problem of medical harm. It is the third leading cause of death in America. And what we find of us who follow this subject is that there really aren't the kind of resources available to address this problem that should be available, considering the fact that it's the third leading cause of death. Now, we don't know that it's the third leading cause of death because these medical errors and infections are not tracked on death certificates. There's no requirement to document them, so they don't appear in any of the lists of causes of death. But we know from a number of studies that 1 in 4 hospital patients are harmed while they're in the hospital, and that includes the full array of harm. Some of those are minor harms, some of them are serious harms. We also have a new estimate of deaths each year. 210,000 to 440,000 people die each year due to medical harm that occurs in hospitals. So part of what we do is try to raise awareness so that more emphasis and more prevention resources and staffing and things like that are available to address medical harm. We use medical harm as an umbrella term to talk about hospital-acquired infections, and I'll say that almost all the data we have on infections and errors has to do with what happens in a hospital. And that's because we have that data, and there are emerging programs to try to collect that data from nursing homes and long-term care facilities, other long-term care services, ambulatory surgical centers, doctors' offices. So there is an effort to try to get a sense of where this is happening so that it can be prevented. But most of what we know is what happens in hospitals. And we know that about 2 million people get an infection in the hospital every year, about 1 in 20 patients, and nearly 100,000 of them die from those infections. The costs have been estimated by CDC to range about $45 billion a year for hospital care alone. It doesn't take care of drugs that you need or wound care or any of the other things that you might need after an infection. Pennsylvania did a study a while ago to try to look at who's paying for it, and it shouldn't surprise you much to know that about 76% of the care for infections is paid for by Medicare and Medicaid. When we talk about other medical errors, that's the other component for medical harm, we estimated there are probably about 7 million a year based on the 1 in 4 figure with the 2 million of infections, at 7 million of errors. And that spans a whole array. It's kind of an umbrella phrase that has a lot of different terms that are used. Somebody in my office recently said, you need a taxonomy on this. Sometimes it's called adverse events. Never events is another common term that's used. But we actually polled people to say, what would you call this? And medical errors and medical mistakes is what people mostly assign to these events. And they include medication errors, surgical errors like operating on the wrong patient, the wrong site, leaving objects in the body after surgery. Includes things like burns, which might occur from surgical fires or chemicals. The other two that people don't normally think about that are very common are serious bed sores and falls when patients are in the hospital. So our work has been, like I said, focused on trying to get information to the public about what's happening, because we believe that until you have the awareness of what's happening and where it's happening, you can't really start to tackle that problem. So in 2003, we drafted a model bill on reporting hospital-acquired infections. We based it on a law that had just been passed in Illinois by a senator named Barack Obama. And we took his model and improved on it a little bit, gave it a little bit more some more consumer twists, and took it on the road and went from state to state to try to get these bills passed. It really resonated with the legislatures. People who served in legislatures thought, well, surely somebody's watching this. Somebody's counting them. Somebody's monitoring this stuff. They called the health department. They called the hospital association. They found out in their states. Nobody really knew how often this was happening or where it was happening. And we were very surprised. The first year we actually took the model bill out on the road throughout the country was actually in early 2005, and 30 states filed the bill. We were pretty surprised. We were expecting 5, maybe 10, but there was a lot of interest in it. And now 30 states have passed laws, and Texas is one of them. And we'll talk about that a little bit later. And in 2012, the federal government started requiring reporting of infections for all the hospitals throughout the country. And so now we've got the whole country covered. But we still feel like it's important for state mandates to stay in place because they have to report all the infections. There are validation exercises to make sure that the data is correct that are going on in the states. There also are opportunities for collaborations around the reporting that's done. And so there's what we found is as these laws have been implemented, there's been a real synergy between the health departments and the hospitals and the public in trying to get change to come. And a lot of it has to do with educating the people who work in the hospitals. In 2011, we also did a model law on reporting medical errors and didn't have quite the same success. There were already 26 states that collected information about medical errors, but they didn't report the information by hospital. Only 6 states report by hospital. Texas does have a law to require medical error reporting, but we haven't seen those reports yet. The other thing we work on is physician oversight. And you've probably read a lot of things in the papers. In Texas recently, there's always controversy. In most states, we are working on a special project in California now, but nationally, what we really want to see is for this agency called the National Practitioner Data Bank to be open to the public. This data bank collects information about physicians who have been disciplined by states, they collect their medical malpractice information, hospital actions against physicians, and Medicare fraud actions. And it puts it all in one place. Doctors are mobile. Many, many doctors are licensed in more than one state, and it's really hard for one state to have all that information. The National Practitioner Data Bank has it all right there, but it's not. It's shielded from the public, and we think that should be public. So last year, we began to work on medical device safety, and when medical devices is the whole gamut, from crutches to blood pressure cuffs to complex implants for cardiac care to joint replacements. It's a whole range. And we focus our efforts on implants and the safety of implants. And we chose to go into this area because it's such a fast-growing market, and the American public really assumes that there is, again, someone watching this stuff and making sure that any high-risk device like an artificial knee or a stent or things that are going into your body have been thoroughly tested for safety. Well, that isn't so. Because the FDA, by law, has 2 systems for testing and reviewing devices. One is a more rigorous process that does require safety testing, and the other one is more of a fast-track process. And it was created for those low-risk devices like crutches and blood pressure cuffs and there's a whole array of devices you can just imagine. But that's what this system is called, the 510K process, because that's the law that created it. And so how that works is the companies just have to show that their device is substantially equivalent to a device that was approved before, or that was, they don't even call it approved, it was cleared to be sold before. And so if you go far enough back in the ancestry of these devices, you find that there was a point in time where everything was grandfathered in that was on the market at that time. So almost 90% of the devices go through this process in order to come on the market. And all they have to show is that they are substantially similar to what they call a predicate, something that's already been on the market. And there's also a loophole. That predicate can even be a device that's been recalled for safety reasons. When we started working on this, we were pretty surprised to hear all this, and I might say that 78% of Class 3 devices, which are the highest risk devices there are, go through the 510K process. So we were pretty surprised, and we got involved in some congressional legislation last year, and we kind of focused on, let's get rid of this loophole at least. And I might say, all of you probably know that the pharmaceutical industry is really a powerful industry. The medical device industry is even more powerful in light of what they're business is. They make billions of dollars every year in profit. They really have a pretty, I would say, good relationship with people in Congress, both Republicans and Democrats, who will speak for them. There is a lot of talk about innovation, saving lives, doing, progress, and we're all for that. But it's not innovation if the device doesn't work, doesn't do what it's supposed to do, and it hurts people. That's not innovation, in our opinion. And so there is a need for, in our opinion, upfront more safety testing on these things. And so we tried to get the loophole out. We couldn't even get that. We couldn't even get them to stop approving devices based on a recalled device. And we got a few changes last year to safety. Our goal is they review the medical device laws every 7 years, and so next time it comes around, we're going to be ready and have a more robust consumer movement to push for change. Not only is the problem up front an issue, but after the device gets on the market, and I'll say, sometimes it's hard to do thorough testing of these devices. You can't do a randomized blind study and have a group have a placebo hip implant and another group have a real implant. It's very difficult to do. And so one of the issues is how do you, when this new product goes on the market, what really happens is it goes everywhere. Everybody says, oh, it's new, it's great, you need it. And we need a slow-down implementation if we're not going to test for safety up front. But on the back end, we don't even have basic things in our system like unique identifiers for each device. Now, you and I know we have identifiers. We have like ID numbers or numbers for our cars. We've got numbers on our toasters. We've got numbers on our phones. We've got ways that you track this product when it gets recalled. You can look at the number and know it's been recalled, or there's a warning, or something has to happen. There's nothing like that on medical devices that's uniform across the nation. And so handling recalls or warnings is really a significant problem. Congress required these identifiers 7 years ago, but it's just now getting ready to be implemented, and it will take a while to implement. We also don't have any national registries like they do in the UK and Australia, where doctors register when a patient gets an artificial hip or knee, and the patient can say, I want my information there too, so if something goes wrong, I get notified. And all that information is used to keep track of the safety of devices. A huge problem came up with a brand new, best on the market, everybody should have a metal-on-metal hip. It was given to young people, active people, because it would last longer, and 750,000 people in the United States got these hips. And they've had extremely high complication rates and high revision rates. And the UK and Australia, their joint registries found these problems way before the United States took any action on that. And one of the things that happens with these metal-on-metal hips is they rub against each other, and small particles, ionic particles, get into the tissue and can destroy the tissue. It can get into your blood and cause all kinds of systemic problems. And most of the problems start at about 10 years. And so the peak of the metal-on-metal implanting happened in 2006. So we're waiting for some real problems in the future. There's also not a really great system for collecting adverse events. FDA does have a website you can go to and say, I had a problem with this device, and the doctor can do it and a consumer can do it. They've recently created a more consumer-friendly system. So hopefully more people will start taking the time to submit problems that they identify. But that's really how the FDA knows when there's problems, is they look at their adverse event reporting system. So we this year started, as Bonnie mentioned, a campaign just a couple months ago, actually, to try to get the top 6 hip and knee companies in the United States to warranty their products for 20 years. And I'm going to talk a little bit more about that in a bit, but that's our current activity, and we'll talk about why we think that's important. I want to speak briefly on how we work. We do lobby, public interest lobbying. We try to change policies. We sit on committees, and we work in Congress. We work in all the states, including Texas. And we work with agencies and hospitals, and there's a lot of work that I do. I do public education and speaking like this. But one of the things that we did, that we started doing different at Consumers Union in 2003, is we started engaging consumers directly. And we wanted to build a movement, and that is exactly what we've done in the Safe Patient Project. We have a consumer-based patient safety movement. It is small. It is it is passionate, but it packs a punch. And one of the things that we do when we start out is that we have accumulated over the last 10 years about 1 million emails from people who are interested in one or all of Consumers Union's issues that include things like food safety and financial services, health reform, patient safety, energy. All those issues, they've come in on many different issues. So we have about 1 million people, and on a couple of times a month, we ask them if they would take action on a particular issue. And that's how we move the hospital infection legislation throughout the country. Many of the legislators who sponsored these bills did not know that it was our bill. They knew that a constituent had told them about a terrible problem, and they filed the bill for that constituent, and that gave it so much power because they were serving their constituency. So we reach out to people and ask them to send emails. Well, sometimes we ask them to do a lot more than that, but that's basically how we connect with them. The other thing we do is we collect stories, and we've become quite adept at collecting stories on all of our issues. And at the Safe Patient Project, we have a full array of story surveys that people can tell us about infections or devices or doctors, whatever, and they have a different set of questions. The stories, and I would say all of our work is pretty much web-based. So you can go to safepatientproject.org and see all of the work we're doing. And it's very transparent. You can see our whole history of work, look up articles, see news releases, and all of that. That's where you submit your stories. These stories are so fundamental to our campaign. When we first went out back in 2003 about asking people for infection stories, we got 37 stories. This year, we went out this summer and asked people to tell us their hip and knee stories. And we didn't ask them to tell us, we just said, tell us your hip and knee story. We got almost 3,000 stories from just our list alone. Most of those people were very satisfied with their hips and knees. About a quarter of them were not. But most of them, all of them, said, gee, I wish I had known more about this device. I wish I did have a warranty on this device. And so we will enlist those people to help us move this issue. We now have about 6,000 stories on patient safety in our bank. And how we use these stories, we connect with people. We enlist them in our army if they are interested in that. And there are a small number of them that are wanting to really get in there and change the system that harmed them or their loved ones. They lobby, they testify. They do a lot of interviews to the media. We move the issue on infections. Every state, there was an article with real examples of people's stories, and that was very powerful. We also network, bring them together to share information and strengthen themselves as a national network. One of the things I thought was, in the many years that I've worked on health policy, when I went to meetings and the hospitals have this network. They have the National Hospital Association. They have State Hospital Association. They share information with each other about the issues. So they don't all have to independently learn about these issues. And so that's kind of what we are building with these consumers. And they are grassroots consumers. Most of them are not connected with an organization other than ours. They are out there working every day on their own in their own states. And my ultimate goal is that every state would have at least one person who is passionate about patient safety and watching what's happening there and raising issues around that. As I said, the media is our best tool to get word out, and many of the stories enable us to get the issues out there. So I'm going to talk a little bit about what we've been able to accomplish and why we think public reporting, for example, is important, because it has many benefits. For example, with the infections, it raised public awareness about the harm. It gives patients a right to know what they need to know about their hospital before they go. It helped them make more informed choices based on evidence rather than, oh, my sister said this was a good place, which is how most of us make decisions, or we like that doctor. Well, did you look him up? You know, those are the kinds of things that should be happening. It stimulated conversations between doctors and patients, because patients could go in and say, you know, I'm worried about this infection. What can you do to make sure that I don't get an infection? And so it stimulated those kinds of conversations. It informed policymakers about the financial and human costs of this harm, and created sort of this dynamic process. Even if you lived in a community that only had one hospital, you could compare that hospital with a similar one in another part of the state and bring some public pressure to bear through the media, through public meetings. Why aren't you as good as that hospital in the other town or across town? So there was lots of conversations that it simulated. It also was a great benefit to the providers. They're always the first ones to use this kind of data. They don't really know how they compare to other hospitals. And these reports actually showed them how they compared. And most of them thought they were doing pretty well, but they really weren't. And so that gives them motivation to rise up and not be at the bottom of the list in the future. It also has stimulated a lot of activity within the hospital, cultural changes, desire to prevent infections because they are identifying them and seeing how many people they're harming. And it really created a thirst for learning about what does the evidence say about how to prevent infections. And that just wasn't really present before. And then there were early innovators. There were hospitals that really got it, and they would get up at national meetings and say, I did these things, and we stopped infecting people. It was a miracle. And everybody else wanted to hear about how they did it and what they did. And so there was a lot of that peer education that came about with the public reporting. These infections are preventable. And that's when I started working on this and initiated this. I thought, why are there so many people getting infected? Why is this happening? I'm looking at all these studies. They say how you can prevent them. I don't understand why they're not being prevented. And a lot of the prevention strategies are really simple. For infections, hand hygiene, which compliance has traditionally been very low, around 50% for doctors, a little bit higher for nurses. And now we're seeing more emphasis on it to move up. Things like screening for MRSA, which is a antibiotic-resistant bug. A lot of people carry it. They are colonized with it. It's on our skin, and it doesn't hurt us. But if we go in the hospital and we're going to have an incision or lines in our body where the skin is broken, we want our skin to be clear of that bacteria. And if we don't, we could get infections. The other thing that can happen is that a nurse could touch our skin and carry it to another patient. And so screening patients for MRSA is one way to identify them, decolonize them, keep them in isolation so that everyone knows you have to use special precautions to keep the spread from that patient to other people. One of the other common infections is ventilator-associated pneumonia, and there was a whole bundle of things that can be done to eradicate that. It's simple as raising the head of the bed of the patient, not keeping the ventilator on the patient if the patient doesn't need it. What they call a sedation vacation. Take a little break on the medication the patient's on to see if maybe they don't need the ventilator anymore, and remove it as soon as possible. Same thing with urinary tract infections. Don't use catheters unless you absolutely need to, and if you do need them, take them out quickly. Often catheters are used on patients because there aren't enough staff, there aren't enough nurses to help the patients, and so with an emphasis on removing those, you have to counter that with an increase in your nursing staff and your helping staff. There are also bundles for other kinds of infections, like sterilizing the skin or sterilizing the spot where you insert lines. And another real important one is engaging patients to alert the nurses and doctors when they see signs of infection. A lot of people we work with who've had personal experiences saw something and they weren't listened to. And I think that we're seeing kind of a change in that attitude, because I think patients are being listened to more now than they were 10 years ago. With medical errors, lots of other prevention ways to prevent. Foreign objects in the body after surgery, you count. They have a count. And they have to count. This is something I learned in one of my committees. The stuff comes in a bag, sealed up, and it says there are 10 items here. Well, you can't trust that. You have to count. Are there really 10 items in there before you start to work? And then when you quit, we have all the 10 items. Can we account for all the sponges and the little tools we used? Is the needles? All of that needs to be accounted for. Wrong site surgery, mark the site. That's what has been a long-standing protocol. It doesn't always happen. Medication errors. There are barcodes. There are names of drugs that sound similar, so people get the wrong drug. Sometimes people get the wrong doses because of the packaging looks alike. For serious bed sores, move the patient around, and that takes staff. For falls, it's also a staffing issue. And generally, I would say the biggest thing that can be done is more nurses and more staff who are dedicated to take care of the patients. Now, on infections, we've been working on this for 10 years, and we're finally seeing a drop. Between 2001 and 2009, we saw a 58% drop of infections, central line-associated bloodstream infections in the ICU, which is the one measure that almost every state has been reporting on and focusing on. And from 2008 to 2011, CDC reported another 41% reduction on these central line infections, 17% on surgical infections, and 7% on the catheter-related urinary tract infections. And similarly, every state that's reporting has reported decreases in the number of infections and the percent of infections, the rate. And so we're showing some progress here. But it's really important to know that we're only really measuring a small portion of these infections, not a whole lot of them. I want to talk a little bit about Texas, because Texas does have some reporting. The law was passed in 2007 and took a long time to get the reports out. We finally saw one issued, the first one issued in August of this year. And it shows that Texas hospitals are doing pretty well. They're below the national average. They've made some progress since 2008. There is some small decline in 2012 of surgical infections. Central line infections, there's more of a flat line and a little bit of tip up, but that tip up is still 45% lower than the national average from 2008. And I keep saying that because that's how we're measuring it. We have a marker. How much progress have hospitals made since 2008? That's how the national government is sort of marking progress. At some point, they'll change that benchmark to a more current date. But still, in Texas, 320 facilities reported, and they identified over 2,000 infections in the state of Texas. And those are just the infections that they have to report on. For example, these central line-associated bloodstream infections, 60% of them happen outside of the ICU. We're not even catching those yet. But that's coming in the future from the federal government. There is also a law that requires Texas hospitals to report medical errors, and I have no idea what has happened to that. But we haven't seen any reports yet. The other thing that I'll touch on very briefly that's made a difference is, I kind of call it a harmonic convergence. We had the consumers, sort of pushing for public reporting. We had some experts who were teaching hospitals how to prevent these infections and writing about them and talking about them. We had CDC who expanded their system to collect information that helped the states implement them. And we had different collaboratives and programs out there doing prevention. And the other thing we had was a thing called Pay for Performance, where the federal government started putting policies on hospitals that if you harm patients, we're not going to pay for that harm. If you fall into the lowest quartile of performers on certain measures like readmissions, which is often connected with errors or infections, that's coming later, you will lose some of your money. In 2014, $1.1 billion are going to be redirected to high-performing hospitals. And I think that, the big thing that we've seen is a culture change over the last 10 years, where when we started, people were saying, as long as I'm average, I'm good. I'm good. But now they're talking about zero. So I want to talk briefly about our warranty campaign, and I can answer any questions you have about the other things that we're doing. But we took this on because, frankly, there's not a lot of progress we can make in Congress right now. Congress is sort of frozen up, and the medical device industry is very powerful in Congress. So we decided to go right to the industry and say, let's warranty your work. If you're so great, put a warranty on those hips and knees. And some of the reasons that we wanted to do this was because of the weak regulation, the weak process up front and the weak process on the back end. Again, also, this is implanted in your body. It's not like a drug or a product that you can just stop using if it's recalled or gives you problems. This is inside your body, and you can't take it out. You can't stop using it. So it's very important that it be safe in the first place. People also don't really have a good idea of how long this is going to last. And they don't know, will this company back it up? And what we're asking in the warranty is that the company pays for parts and labor if the product fails. That's my timer there. If the company fails, if the product fails within the time period. And we're asking for a 20-year warranty. We think these should last 20 years. A lot of people are telling us that they're being told it'll last 20 years. Some people are being told these hips and knees will last a lifetime, but they really don't know. So the number is not as important as how long will the company back up their product. And I've mentioned, we've had some pretty spectacular failures, and on our website there's a whole list of recalls. There's a report on recalls on hips and knees, and all of these 6 major companies have had recalls. The goals of the campaign is to make devices safer and to make the companies accountable for the performance and to inform patients of the true lifespan of the device. So I think I'll stop there and see if there are any questions, and we can talk a little bit more about.
Raise your hands high. We have a question here from Pat Beulah.
Hi. Is all of this information on your website, or some of it, or we'll get a copy of it for the church? I want to send some of this information to an acquaintance that I know in Illinois. She had a hip replacement several years ago, has had all kinds of problems, infections, on, and she's gone to another doctor who says all the problems you're having is related to your device, and you need to have that replaced. However, she got in so much pain that she got, I think, addicted to painkillers. She's got to reduce the painkillers, before she can have the new surgery. It's a mess.
What you're describing is what we see often. If one thing goes wrong, there's sort of a snowball effect. All these other different things happen in your life. Yes, this information is on our website, safepatientproject.org. There's a banner at the top where you can go to the different topics, and we have all of our warranty information on one page. So you can find our information about the warranties on those pages. And these are the kind of stories that we hear quite frequently. So we would love for her to share her story. Yes.
We have a question from James Bryce. Would you stand up?
Yes. I was wondering, you were talking about medical safety. Do you ever get out in the public and try to, debunk the vaccine hysteria, like how vaccines might cause autism, that type of hysteria?
I'm not personally working on that, but Consumer Reports has done a significant amount of work on that. We have a program called Best Buy Drugs that gives people the best evidence of new drugs and information. And Consumer Reports has written about the vaccine issue quite frequently. And there is quite a movement, sort of coalitions to try to counter with evidence and facts some of the concerns about vaccinations. And Consumers Union Consumer Reports has participated in some of those collaborations.
Lisa, can you comment on the safety of neurostimulator implants, spinal implants? Is that something that is on the radar yet?
It's not one of the things that we're focused on right now, so I couldn't comment on that.
Okay.
But I would say it probably was approved through the 510K process, so it probably hasn't been tested for safety. And again, the important thing is on the back end. Some of these products have been on the market for a long time, and we should have information about it. If we had a registry, we would. But we don't have any way of tracking. And what's happening in this country, as you might not be surprised to know, is we are very entrepreneurial, private sector, everybody does their own thing kind of process in our healthcare system. And so some big systems like the Kaiser HMO in California has their own registry. The state of Alaska is creating its own registry. There are the Orthopedic Surgeons Organization is creating its own registry. And our problem there is, what are consumers going to see? They're going to control the information, but are we going to know what they're finding? Those aren't public entities like the registries in the UK and in Australia.
We have a question from Douglas Bauer.
Thank you, Lisa, for a very interesting presentation, a lot of good information. If I wrote the numbers correctly, I believe you said that 5% of the people who go to the hospital get infections, and that results in 100,000 deaths per year, which I found pretty staggering. I think about back in 2001, where the death of 3,000 people in a terrorist incident was used to justify $1 trillion of expenditures in wars. You also said that a lot of these infections are due to the lack of staffing in hospitals. My question is, what are the consequences of that sort of thinking, and what should be done about increasing the staffing in hospitals?
Well, if anyone's been in the hospital recently, you know that there often is a shortage of nursing and even nurse extenders, other staff that help nurses. There really needs to be pressure from the public to private hospitals to have better ratios of nurse to patient. And I think that's really what has to happen. Every day, hospital leaders, CEOs, CFOs, make decisions about how to spend their money. And they are not making decisions to spend their money on more staffing. They're not making decisions to spend their money on more safety programs. They're making their decisions to spend their money on something that can bring in more profits, typically. A new parking lot, a new business office, new MRI machines that might not be needed. Things like that is where those decisions are being made. And I think that a lot of the programs that are going on now are putting pressure on them. They're going to start losing money if they don't improve their safety. And that's really been a good stimulator of change, I have to say.
We have a question from Richard Halpin.
Thank you, Bonnie, and thank the Unitarian Forum for such a great job in bringing you here. You've done a terrific presentation today. Thank you. Two quick things. One, if we wanted to write up what we heard from you today for our newsletter here at the church, could we do that? Could we follow up with an interview with you or something like that?
Absolutely. And I will make my presentation available to whoever wants it. I'll work through Bonnie to do that.
Okay. And secondly, new devices are coming on the market all the time, it seems. Knuckles and ankles and thumb joint replacements. Can you comment on any of those new devices and if they'll go through the same dubious process or what's going to happen with them? Take ankles for a specific example.
Well, I haven't done a lot of research on ankles, but I know that ankles are an up-and-coming product because the Australian registry is talking about it. So that's how I know. I don't know from anything in the United States. I'm not sure if there's always been, if they're going to go through this fast-track process in approval, but my guess is that after the first one gets out there, then everything else will be what we call iterative. You know, a lot of these device companies go to Congress and say, well, these new products are innovative and they're great new breakthroughs, but the truth of the matter is most of them are simply a tweak, a tweak, a tweak. They're not innovative. They're fixing error, fixing mistakes and things like that. And so all those changes are, hopefully improving the product, but FDA has to put it through the system, and there's still no way to know if they're safer. You know, like the metal on metal hips, they were same as something that was metal on ceramic, but just different materials. Well, those different materials made a big difference, and those materials weren't tested for safety. In fact, there was evidence in the past that when you put metal on metal together, you do produce these particles, and no one really paid a whole lot of attention to that.
We have a question from Jim Bryce.
Thank you very much for your presentation. I'm interested as a policy matter on how things might work. You've mentioned the UK and Australia and how in a way they've gotten ahead of things. Here in the States, for years, none of the issues you've mentioned were really talked about or dealt with in Congress or legislation because they were handled in medical malpractice lawsuits, which have been essentially decimated in most states because of tort reform making them uneconomic. But we see these other countries that you've mentioned going ahead of us in analyzing these products. What techniques might be introduced, or how can we use that as persuasion to get Congress and our legislatures to introduce the techniques that are putting these other countries ahead?
Well, I think that the biggest persuasion is going to be making them really understand the amount of harm that's being done. And unfortunately, it's often some disaster that moves the policymakers in this country. Those of us who have worked on health reform for a long time have thought once we get everybody to have access to health care, then we can start, everybody will really be focused on things like safety and quality. But that's going to take a while. We've still got a lot of work in implementing the new health reform laws. But I think that I think that it's really difficult to move Congress, for example. And what we found with the infection reporting is by raising awareness at the grassroots, we were able to sort of bubble up instead of top down. And finally, after about 5 or 6 years, the feds started saying, well, we should probably track these, and then it was palatable. Where if we'd gone straight to Congress, we would not have gotten it done. So the policies are difficult, and there's a lot of money in politics. There's a lot of money on these issues, and we have to just keep trying to raise awareness, and typically through patient stories, and people who are represented by these members of Congress are the ones that can get to them.
We have a question from Martha Schumacher.
You have said it very well. We have too much commercialism in this country. I have to have knee replacement, but I've been putting it off because I've been reading these advertisements. I may have to go to Canada or maybe the UK, as you've mentioned. Can you give me the name of a particular product? You see these advertisements, which shouldn't be, like Stryker. How is Stryker, how is that rated? Or can you give me it's a total knee replacement that I have to have.
Well, we aren't rating companies, but you can look at recalls online with the FDA, and we did do a recall report and show the number of recalls over the last 10 years of Stryker for knees and hips. So you can look at it's on our website, but we don't recommend products, and Consumer Reports isn't rating these products at this point. I think looking at the UK registries, there's the National Joint Registry is NJR UK, or just Google it and you can pull it up. And the Australian Joint Registry, they have a wealth of information, and these are the same devices that are being implanted in the United States. So that information is just as useful. I want to say one more thing to get back at the question that this gentleman asked. Our system is so fragmented, which all of you know. When we first started working on warranties, the first thing we wanted to do, we wanted to make the patient whole. We wanted to come up with a warranty that covered everything, that everything that could go wrong, infections, errors. We wanted to make the hospitals accountable and the doctors accountable and the medical products accountable. But it was just too difficult. We could not pull it together. So that's why we're focusing on the product. It just so happens that there are some pilot projects through Medicare that are looking at what they call bundle payments, where for hips and knee replacements, where certain clinics are saying we're going to guarantee that, we're getting paid a certain amount of money to make sure that you get out of this procedure safely for a certain period of time. And we're also working with a collaboration in Washington State that has developed a model warranty that includes doctor and hospital care, and we're going to work with them on trying to get the products as part of that. And that is going to be possibly something used by the state and as many facilities or providers in the private sector who wish to do that. But if we can make that happen, it'll set an example, and it's something that we can spread around the country, and I think it'll be a really good model for the future.
How many minutes do we have left, Becky? 5 minutes. Okay. Question from Vicki Valadez. Would you stand, please?
Thank you for being here today, and thanks for all the work that you and the rest of the team do. I was curious as in terms of, since it seems like there's been sort of it's taken a while for hospitals to pick up and start reporting on medical errors and infections. You said there's been innovators that have sort of taken on that responsibility. For the people that were sort of slow in getting in the process, has there been resistance, or what's been keeping people or hospitals accountable in terms of not reporting fraudulently?
Well, I think initially a lot of hospitals were fearful about the reporting. They thought it was a waste of time. But I would have to say now it's sort of the way things are. They might not be happy about it, but they accept it as a way of doing business. And they have probably found some benefits from it. That they're probably, there's a benefit from looking at your statistics and looking at your statistics compared to another hospital. So I think there has been a real change in attitude. There's also been a real cultural change, and I haven't talked much about this, but it's sort of new patient-centered care, which seems kind of ridiculous. Well, who else is at the center of healthcare if it's not the patient? But in fact, it hasn't been. And so there's a real movement to try to reorient the way healthcare is delivered so the patient has a role and is thoroughly engaged. And that can make all the difference. We still have people in hospitals who resist and think we shouldn't be doing this, and they certainly don't want to report more, which is what we want to happen. But we're going to keep pushing, and, there will be resistance, and then people will accept it eventually.
We have time for one quick question. Would you stand and say your name, please?
Hi, my name's Charles Cratch. So you mentioned that legislation was passed in 2008 in Texas to generate reports on hospital-acquired infections, but then you didn't actually see any of these reports until this year. So in those 5 years, how did, as a patient advocate, did you keep motivated in the face of nothing actually happening?
I went to other states, but I worked in Texas for a long time, and you know, I was on every state established an advisory committee, and a lot of the activists that we've connected with who had personal stories serve on these advisory committees around the country. And I served on the advisory committee here in Texas for several years, and now one of the activists in Texas has taken my place. And in fact, his name is John James. He's from Houston, and he's the person who just published the new estimate of how many people die from medical harm. He's a NASA scientist. His son died due to medical harm, and he is an activist, and he has turned this into, scientifically looking at what is happening. But, you know, in Texas, you just have to kind of keep going. You just have to keep going, and soon enough, it will happen.
Would you take just a few seconds and perhaps make some final comments and before we close?
Sure. I think what I would say is one of the things that people can do is maintain an awareness that these things are happening. We're not trying to scare people from going to the hospital, but if you go in with your eyes open and ask open questions to your doctors and the hospitals about what is going on, what systems are in place to keep patients safe, those are the kind of dialogues we want to have. And always speak up. It's very, very hard for patients to speak up in situations when they're vulnerable and sick. The number one thing we tell people when they're in the hospital: have somebody there with you as your advocate. It can be a friend, a family member. It is the recommendation of every expert, but that is the best thing you can do, and to speak up when things don't seem to be going right, because that can save your life. It can save the life of a loved one.
Lisa, thank you for sharing such vitally important and life-saving advice with us, and I hope many of us will become advocates for patient safety. Thank you again.
Thank you.